नमस्ते बेटिया, हमेशा खुश रहो। Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at the Faculty of Homeopathic Science and Jyoti Vidyapeeth University. This is a series of water and electrolyte imbalance. In this series, we will be studying about disorders of sodium metabolism. In this lecture, water consists of 60% body weight. The fat contains less water, and obese people have less body water. The water in the body is distributed into two major compartments. One is extracellular fluid and the other is intracellular fluid. Intracellular fluid or ICF consists of 66% and extracellular fluid, that is ECF, consists of 34%. ECF is further divided into interstitial fluid 65%, intravascular fluid 25%, and transcellular fluid 10%. In the intravascular compartment, only 10% is in arterial system, 55% are in capillary system, and 35% are in venous system. Body fluid distribution. Body fluids are distributed in two distinct areas. This is the division of what we have studied. Intracellular fluid consists of 40% body weight, and extracellular fluid consists of 20%. Interstitial fluid 15% of the body weight, and plasma consists of 5% body. Fluid compartments are separated by the membrane that are freely permeable with water. Movement of the fluid due to hydrostatic pressure and osmotic pressure. The composition of fluid in the intra and extracellular compartment are entirely different. These are certain points or the sites where we have different proportion of what the concentration that is described in this table. So the site outside the cell or inside the cell. Outside the cell is known as extracellular fluid, inside is intracellular fluid. In the extracellular fluid, the protein content is less, whereas in intracellular fluid, the protein content is more. The major cation in extracellular fluid consists of sodium ion and, in a lesser extent, potassium and calcium ion. In the intracellular fluid, the major cation consists mainly of the potassium ion and minority of magnesium ion. The major anion in extracellular fluid consists of chloride ion, and in the intracellular fluid, the major anion is phosphate ion. What is the requisite for a biochemical laboratory investigation? Number one, to screen an asymptomatic subject. For screening out any disease in an asymptomatic subject, biochemical lab investigation is done. To assist in the diagnosis of patients presenting complaint. To monitor changes in test results as a marker of disease progression or response to treatment. The normal sodium metabolism. Normal plasma sodium concentrations are between 135 millimole per liter to 145 millimole per liter. First of all, we will be starting with sodium metabolism. The main determinants are water intake, thirst, or habit. Non-sensible losses occurs in the sweat and urine. Hormone arginine vasopressin, or the ADH, plays important role in the metabolism of sodium. The disorders of the sodium metabolism can be categorized into two categories. The disorders due to sodium excess, that is known as hypernatremia. And second, the disorders due to deficiency of sodium, that is known as hyponatremia. Sodium excess or hypernatremia. Hypernatremia is a common electrolyte problem that is defined as a rise in serum sodium concentration to a value exceeding 145 millimole per liter. Hypernatremia is caused due to a number of factors which are classified on the basis of clinical condition pertaining to volume of water in the body. Excess of sodium or hypernatremia can be classified into on the basis of three symptoms or on the basis of three conditions: hypovolemia, hypervolemia, and euvolemia. Hypovolemia occurs due to dermal losses, especially in the condition of burns or excessive sweating. Gastrointestinal losses occurs in the form of diarrhea or vomiting. Diuretics administration can lead to hypovolemia. Acute or chronic renal disease can also result in the condition of hyperosmolar non-ketotic coma is also responsible for hypovolemia and causing sodium excess. Hypervolemia can occur due to iatrogenic causes, that is, hospital-associated causes in which administration of hypertonic saline, tubal feeding, or hypertonic dialysis. And the other condition of hypervolemia consists of hyperaldosteronism. Euvolemia. Euvolemia with hypernatremia occurs in diabetes insipidus. Hypodipsia, that is decreased thirst, fever, and hyperventilation. Clinical features of hypernatremia consist of peripheral and pulmonary edema, pleural effusion, and ascites. Systemic hypertension increases in ECF volume causes hypervolemia. It occurs in primary aldosteronism and acute glomerulonephritis. Edema with signs of hypovolemia, postural hypotension, poor peripheral circulation, and anemia. It occurs in hypoalbuminemic states. Investigation consists of plasma sodium level, that is usually normal, may be low if the water is retained, and raised in pulmonary aldosteronism, primary aldosteronism. Management. Diuretics can be administered. Plasma protein infusion if hypovolemia is life-threatening. Aldosterone antagonist in Conn's syndrome. Chemo or peritoneal dialysis if inadequate response to diuretic therapy. Now we come to the second condition of sodium metabolism disorder, that is hyponatremia. Hyponatremia is a low sodium concentration in the blood. It is generally defined as sodium concentration of less than 135 millimole per liter. Symptoms can be absent, they can be mild, or they can be very severe depending upon the concentration of sodium in the blood. The causes of sodium deficiency or hyponatremia includes excessive sweating, GI fluid loss, gastrointestinal fluid loss that can occur in vomiting, and diarrhea. Excessive renal losses with mineralocorticoid deficiency, Addison's disease, and hypoaldosteronism. Renal salt-based chronic pyelonephritis, renal calculus, analgesic nephropathy, diabetes mellitus, excessive diuretic therapy, excessive ultrafiltration by hemo or peritoneal dialysis. The clinical features consist of sunken eyes and cheeks, weakness, faintness on standing, muscular cramps in legs, thirst, cold hands and feet, skin becomes inelastic and low intraocular pressure, tachycardia and weak pulse, postural hypotension, and ultimately circulatory collapse and death. Investigations that could be performed includes plasma sodium concentration, which can be low or normal, raised plasma urea or creatinine level, and impaired renal function. The fluid input-output chart and daily weighing of the patient. The management of acute hyponatremia carries the risk of cerebral edema. The management is essential because if that is not done in the cases of acute hyponatremia, then it can lead to cerebral edema. Fluid restriction less than 1 liter per day is initial approach. Demiclocycline is a drug of choice, and aquaretics, that is, lixivaptan, induces photodiuresis without affecting urinary electrolyte or solute excretion. The next lecture, we will be discussing about disorders of potassium metabolism. In this lecture, we have covered sodium metabolism. In the next lecture, we will be discussing about disorders of potassium metabolism. This session is powered by Digital Version 2.0 of Jyoti Vidyapith Women's University. I hope you are satisfied with my digital session. If you have any problem or query, then please mention it in the comment box. I will try to resolve it. This was all for now. Thank you.